Here are some common technique problems. The needle bevel is not facing towards the tooth. If the bevel doesn't face towards the tooth, the injection will not work as well, and for the patient, it'll be a lot more uncomfortable. Have the bevel facing towards the tooth. The needle not contacting the tooth. In this situation, the injection will be much more painful for the patient. The needle should be hugging the root surface throughout the entire injection. If the needle bevel is not facing the tooth, it may become occluded with bone as it's advanced. If the needle bevel is not kept in contact with the root, the needle tip may come into premature contact with the crest of bone. If the needle shaft inadvertently deflects off the height of contour of the tooth, the needle tip may wind up in the soft tissues. This will produce a lot of blanching of the soft tissue, but will not produce pulpal anesthesia. If the needle tip is not advanced far enough into the PDL, a seal will not be formed around the needle. When the anesthetic is delivered, it'll flow back into the patient's mouth. An anesthetic doesn't taste very good. The needle should be advanced as far as it can until resistance is felt. Throughout the injection, it is also important that pressure be maintained on the needle to prevent the anesthetic from flowing back into the patient's mouth.
Once you've concluded the PDL injection, discontinue the foot pressure and allow 4 or 5 seconds to elapse before removing the needle. Failure to do this will cause a pressure squirt of anesthetic in the patient's mouth.
The last of our technique problems, and perhaps one of the most important, is the volume of anesthetic that must be delivered in the PDL injection. It is very important that 0.9 mLs of anesthetic be deposited per injection site. Some of us have expressed concern about the volume of anesthetic being recommended in this injection. A volume of 0.9 mLs per injection site deposited slowly under controlled flow will not produce any postoperative pain or discomfort. The anesthetic in this injection will diffuse from the injection site into the interproximal bone and will not produce any soft tissue damage or postoperative pain and discomfort. Here are some frequently asked questions. My needle stops, I administer the local anesthetic, and I see blanching, but I don't get any pulpal anesthesia. What is likely happening is the needle is impinging on the crest of bone. The anesthetic then is diffusing into the buccal soft tissue. You're not getting any pulpal anesthesia. To correct this, make certain that your needle is in contact with the tooth the entire time, and this way it will advance into the periodontal ligament space. I see blanching going all the way down to the floor of the mouth. Again, I don't have pulpal anesthesia. In this situation, the needle is likely to be lingual aspect to the alveolar bone, and the anesthetic is in fact diffusing into the floor of the mouth. To correct this, advance the needle along the tooth. Keep the bevel along the tooth and slide it again into the PDL before depositing the anesthetic. The anesthetic squirts into the patient's mouth as I'm depositing it. Two possible problems here. The first and more likely is that you have not advanced the needle far enough into the PDL. A seal is not being formed, and the path of least resistance is for the anesthetic to simply diffuse back into the oral cavity. The second possibility is you're in far enough, but you don't maintain a downwards pressure on the needle throughout the injection. Again, that breaks the seal, allowing the anesthetic to diffuse back into the patient's mouth. Pulpal anesthesia doesn't last long enough. One possibility is a simple one. Drugs affect different patients in different ways. Even though a drug may provide 1 hour's worth of pulpal anesthesia, in some patients it won't always. Another possibility, and a very likely one when doing the PDL, is you didn't deposit an adequate volume of anesthetic. Why not 1 in 50,000 epi? Experience has shown that the ischemia or blanching that occurs in the PDL injection with 1 in 100,000 epinephrine is more than adequate to provide profound anesthesia of the tooth and the soft tissues. There's really no reason to use as much epinephrine as is found in a 1 in 50,000 concentration. Why do we recommend a volume of 0.9 mLs when other PDL injection techniques recommend a volume of 0.2 mLs per injection site? One of the reasons is that we are dealing with a totally different fluid dynamic. We are depositing the anesthetic slowly under a constant pressure, so the anesthetic will diffuse along the path of least resistance. With other techniques, a smaller volume is placed under high pressure. In that situation, more patients will have postoperative discomfort. When the larger volume is placed in slowly, it is rare to have a patient complain of post-anesthetic discomfort with the PDL injection. Some of my patients mention that their tongue or lip get numb following the PDL injection. In our experience, this is entirely normal in some patients. In doing the PDL, everything feels right. No anesthetic is leaking into the patient's mouth. However, there's no blanching, and when I remove the needle from the patient's tissue, a lot of anesthetic flows into the patient's mouth. What is happening is improper technique. If the bevel is facing against the bone, it is likely that the needle will become obstructed by the bone, preventing the blanching from occurring and preventing the anesthetic from flowing out. When you remove the needle, the pressure inside the tubing will force the anesthetic into the patient's mouth. This can be corrected by simply having the bevel of the needle facing the tooth and advancing your needle with the bevel in contact with the tooth until resistance is met. This will prevent the needle from becoming obstructed with bone.
Now that you've had an opportunity to review the periodontal ligament injection with the wand, we believe you'll find this an excellent technique which is predictable, easy, and more comfortable for your patients.